Hello students, let us discuss some environmental emergency conditions, right? In which the first condition which I will discuss with you is anaphylaxis. Now what is this anaphylaxis? Well, we need to know the management of anaphylaxis. Every emergency physician should know how to manage anaphylaxis, right? So how do I approach a patient in anaphylaxis? Before approaching, we need to know what is anaphylaxis, how it is different from anaphylactoid reactions, what is the different type of presentation which anaphylaxis can produce, etc. So little bit, not very much in detail, little bit about anaphylaxis. So what is anaphylaxis? Anaphylaxis refers to characteristic and often life-threatening clinical manifestation of immunoglobulin E mediated, mast-mediated hypersensitivity reaction involving mast cell degradation leading to histamine, tryptase and prostaglandin leukotrienes release, right? So what is anaphylaxis? It is a life-threatening clinical manifestation which is IgE mediated, right? It is a hypersensitive reaction involving mast cell and basophil degranulation. The mast cell and basophil, they degranulate, and because of this degranulation there is a release of histamine, release of tryptase, release of prostaglandin and leukotriene, right, which is incited after exposure of various substance, right? So how it is different from anaphylactoid reaction? Anaphylaxis is different from anaphylactoid reaction. So clinically, anaphylactoid reaction is indistinguishable. It is same as anaphylaxis. But unlike anaphylaxis, which is IgE mediated, anaphylactoid reaction is not IgE mediated. It is a direct mast cell degranulation, right? It is a direct mast cell degranulation. Causes of anaphylaxis. There are various conditions which can cause anaphylaxis, like food, like nut, eggs, fish, milk, antibiotics, vaccines, anesthetic agents, insulin and other hormones, antitoxins, blood and blood products, insect bites, snake bites, latex, allergy, immunotherapy. All these can cause anaphylaxis, right? Now anaphylactoid reaction, that is not IgE mediated, it is local mast cell degranulation, can be caused by NSAID, opiates, sulfite, radiocontrast media, neuromuscular blocking agents, gamma globulin, anti-sera and exercise, right? Now how do they present? What is their presentation? We are talking about presentation of anaphylaxis or anaphylactoid reaction, both. They can present within minute of exposure, usually less than 1 hour after exposure. Immediately after exposure to these substances, the reaction can precipitate, but it is usually in less than 1 hour. Rapid on parental route, rapid reaction on parental route. If the precipitating substance is given IV, the reaction is more rapid. First symptom, flushing, pruritus and sense of doom. Patient shows flushing, intense pruritus and intense sense of doom. Patient becomes very depressed. So these are the first symptoms of anaphylaxis reaction. What is the clinical presentation? Clinical presentation. Clinical presentation can happen in each system. We'll go system by system. Eye. What can be seen in eye? Pruritus, lacrimization, conjunctival edema, periorbital edema. Cardiovascular, hypotension, tachycardia, arrhythmia, cardiac arrest, right? Initially it would be hypotension because of vasodilatation, because of hypotension, tachycardia, arrhythmias can happen, it can lead to cardiac arrest. Gastrointestinal manifestation, nausea, vomiting, diarrhea, abdominal pain. Skin manifestation, pruritus, flushing, urticaria, angioedema, etc. Respiratory, dyspnea, stridor, difficult swallowing, pulmonary edema, anything can happen. Neurological, anxiety, sense of doom, seizure can happen. So, immediate treatment is indicated for all patients with significant respiratory, cardiac and gastrointestinal symptoms. So, we need to give an immediate treatment. And remember, there is no absolute contraindication of giving epinephrine to any patient. Epinephrine does not have any absolute contraindication. And this is one drug which is drug of choice in anaphylaxis. Okay, so how do I manage a patient in anaphylaxis? Airway, breathing, circulation, like any other patient. Early intubation is mandatory in these patients because airway edema can lead to airway obstruction later. So later on, maybe I'll have to do a cricothyroidotomy, or if my patient presents little late, maybe I won't be able to intubate. I have to get prepared for cricothyroidotomy, right? Breathing, we have to give oxygen to our patient. We start giving our patient oxygen, and for circulation we put 2 large bore cannula, and once I have put the cannula, as fast as possible I give IV epinephrine, right? And definitely I attach the cardiac monitor. Epinephrine is drug of choice in managing anaphylaxis. IM epinephrine, if I am giving it IM, I have not secured the IV cannula yet. The dose is 0.3 to 0.5 milligram, 1 in 1000 dilution, anterior or lateral thigh. We give it in anterior or lateral thigh. And if I give IV epinephrine, then 0.1 to 0.2 milligram, 1 ml if we take 1 ml of 1 in 1000, add 10 ml of 0.9% normal saline to it, and we can give it every 1 to 2 minutes. So it has become 0.1 milligram per ml. So every 1 to 2 minutes, I give 0.1 to 0.2 milligram, right? I give 0.1 to 0.2 milligram. If patient responses to epinephrine, the symptoms starts decreasing. We give our patient H1, H2 blocker, both. Diphenhydramine H1 blocker I give 25 to 50 milligram IV, and ranitidine H2 blocker I give 50 milligram IV. So if patient has a response, I give H1, H2 blocker. If there is no response, right, there is no response to adrenaline, then I can go for glucagon 1 to 2 milligram IV IM every 5 minutes to effect. For continued hypotension, patient is having continuous hypotension, I may start epinephrine infusion 0.1 microgram per kg per minute, titrated to effect, and start a continuous aggressive fluid resuscitation if patient is not responding to adrenaline, which is very unlikely in anaphylactic shock. We give a glucagon, and for continued hypotension, I start epinephrine infusion and continue aggressive fluid resuscitation. Remember, in anaphylaxis, there is no role of giving steroid in acute phase, but steroid has a role to prevent the phase 2 reaction stage of anaphylaxis. So maybe once the acute stage has gone, I may give a dose of steroid, but in acute phase, for management of anaphylaxis, there is no role of steroid, right? So once patient has stabilized and no known cause of allergy has been discovered in that patient, what has exactly caused it, then we refer the patient for testing and monitoring to an allergist. If a known cause of allergy can be identified in that patient which has led to this anaphylaxis, then it is mentioned in his medical record and medical books, and maybe a band attached to the patient that he is allergic to that particular drug for future. Okay, thank you.